Yeah, so I think we're going to get started and jump right in. Welcome, everybody. My name is Heidi Estrada, and I am the Community Involvement Coordinator for the chapter. And we're really excited to have several researchers here to tell us about research programs happening in the Boston area. And just a quick note that we will have opportunities to ask questions after each presenter. And at the conclusion of this, we will email all of the participants contact information, numbers, and things like that. So if you do want to ask further questions or get more information about studies that you might be interested in participating in, you can do that. I'm going to just turn it over very quickly to David Estrada.
Hi all, welcome. Thanks for coming. And we'll kick it off right now because time is going to be a little short, possibly towards the end. But Nancy Latham, Sarah Skeels, and Nicole are going to present on a couple studies that are happening at Brigham and Women's Hospital. So I believe we've got you on shared screen, Nancy, Sarah, and Nicole, so you can kick it off. And welcome.
Thank you. Thank you so much, everybody. My name is Sarah Skeels. I am a member of this research team from research program in men's health, aging, and metabolism at Brigham and Women's. I'm someone that's been living with a spinal cord injury for over 30 years. And I'm just here to introduce these two exciting studies we're a part of. And Nicole is going to talk about one of the projects. They're both physical activity and exercise based. And Nancy's going to then Nicole's going to talk about the first one, which is called Silinx. And then Nancy's going to talk about Fit SCI, which is an FES-based project.
Great, thank you, Sarah. Good morning, everyone. So my name's Nicole, and I'm going to be talking about the Silinx project. And the overall goal of this project is really to develop a physical activity and social networking app that's specifically designed and targeted for people with spinal cord injury. So we call this app Silinx, and Silinx addresses or aims to address two common challenges that are very prevalent among people with spinal cord injury. So those are physical inactivity and loneliness. And this project is currently taking place in 2 phases, and we're actually just wrapping up the first phase of our project. So the goal of phase 1 was to have a series of focus group sessions with people with spinal cord injury and to gather their feedback and incorporate it into this app that we've been working on over the last couple of months. So we've been using this feedback as a very user-centered design process to incorporate the feedback and create something that we believe will really help people with spinal cord injury in those 2 areas of physical activity and social connectedness. So what we really need from you, because we're wrapping up phase 1 and that round of usability testing just about now, but we need your help in phase 2. So this is our pilot study, and enrollment for this will begin in early December. So we've included a few screens of the current app, which is built out, and this will allow you to share your experiences and connect and begin making connections with others, potentially tracking your activities and joining challenges. So maybe a little bit similar to social networking apps that you've seen before, maybe some exercise-based apps, but again, this is designed specifically for people with spinal cord injury. So users will be able to create a profile and share as much or as little information about themselves as they would like to. So you can add information about the activities that interest you, maybe new things that you're interested in trying as well. Users will also be able to track activities that you're doing by selecting activities that they're interested in. So this will allow them to select activities from existing activities that we've populated in this app, or they can select their own if they don't see something that interests them or catches their eye. So you can track these activities and start sharing them with friends as well. So this app develops personalized reports based on the activities that you do. And again, you can share these activities, you can track your progress, and the things that you do will pop up on your friends' dashboards. You can have the ability to give a comment or give a thumbs up, maybe like you've seen on some other networking apps. So this really allows you to get some social interaction and really connect with other people who have spinal cord injury. So this really helps address those two main pieces that we're looking at, which is the social connectedness and incorporating that physical activity piece. So for phase 2 of the pilot study, we've included a little bit more information. So we're looking for 50 people with spinal cord injury that are 18 years of age or older. So we're hoping that these individuals will have about 25 that will download and use the Silence app for 2 months, and 25 will be in the control group, but they'll also be able to download the app and use it after 2 months has passed. One thing that's really nice about this study is that there's no need for travel, and all the assessments and study procedures will take place remotely, either by phone or maybe by video conferencing. Some of the main things that we're going to be looking at with this project is acceptability and usability, just so we can take a look at that, as well as loneliness, social isolation, and physical activity. There'll be some compensation for this app for participation, and we begin to start enrolling participants sometime in December. So just a couple of weeks away. If you are interested in maybe learning more information about this, my email address is included there, and I'm happy to share that with anyone who might be interested. So if you have some interest, some questions, we're happy to share that with you, and we will contact you when enrollment gets started. So I will pass it off to Nancy now to talk about one of our other studies.
Thank you so much, Nicole and Sarah. I really appreciate the opportunity to be part of this session today and to talk and answer questions about this next trial, which is called the Multimodality Intervention to Improve Function and Metabolism in Spinal Cord Injury Trial. That's really long. We refer to it more commonly as the FIT SCI trial, as Sarah introduced it. Next slide, please, Nicole. The PI of this trial, the principal investigator, is Dr. Shali Basine, and we have a really large group of people with different skills and backgrounds collaborating on this. Many people from Brigham and Women's Hospital, and also people from Spaulding Rehabilitation Hospital. We're grateful for funding from this, from the National Institute of Health, from the NCMRR Institute of the NIH. Next slide, please. It's well known that osteoporosis and the loss of muscle mass are common and serious problems for many people after SCI. What is hopeful is that in people with other conditions, there's increasing evidence that these problems can be addressed by a combination of anabolic drugs to enhance muscle and bone, plus an exercise program. However, up until this point in time, there has not been a reliable and carefully done randomized controlled trial that's large enough in people with spinal cord injury to find out if this is a good approach for people with SCI. So the question that this trial is trying to answer is, could this combination of an anabolic drug to improve muscle and bone and an exercise program improve outcomes with muscle, bone, and also outcomes that matter to people in their function and other well-being in people with SCI? Next slide, please. This is a randomized controlled trial. We will enroll a total of 88 people. Everybody in this trial will take part in the exercise program, and that program is using functional electric stim for a leg cycling program and voluntary arm ergometry. That exercise program takes place for 16 weeks. In addition to the exercise program that everybody gets, people will be randomly assigned to receive either the anabolic therapy, which is testosterone, or a placebo, and these are given by injection. The inclusion criteria are, we're looking for both men and women for this trial, age 19 to 70 years of age, that have a confirmed spinal cord injury from the C7 to T12 level, people who are at least 6 months after their injury, and who use a wheelchair as their primary mode of mobility. We are wanting to include people who are medically stable at this time and are able to perform arm exercise. Next slide, please. The primary outcome for this trial is aerobic fitness. We're looking at a number of other secondary outcomes as well, including measures of muscle, bone, metabolic outcomes, as well as self-reported measures of people's function, mood, or other well-being measures. Next slide, please. For people taking part in it, what might help be seen as benefits to people include the fact that for the time commitment that this trial involves, you are compensated for a total of $830. You also are given, for the duration of the trial, of the 16-week exercise program, in-home use. It will be delivered to your home, an FES exercise bike and arm ergometer that you can use. You also receive exercise coaching, MRI, and other preventative diagnostic testing that might be of interest to you. We also cover the cost of your transportation or meals for the days you need to come into Brigham and Women's Hospital to have the lab tests. We are enrolling people in the trial right now. If you are interested in learning more, finding out more of the details about this, we would welcome you contacting us. The person to contact is our research coordinator, Catherine Gaddis, who's at this email address that you see here. So we would be happy to answer. I think we've got a little bit of time for questions now. Any questions that you have to any of the three of us about any of these studies. And these again are the email addresses for the app study that Nicole spoke about, the first one, or for the fit size study that I just spoke about. Thank you. Someone raised a hand.
Yes, I have a question about, do you expect, have there been shown to be aerobic improvements associated with the FES bike?
There have been in other populations, like we're using both the FES bike, but in addition, we're using the arm ergometry. So I think some of the improvements will be coming, we think, from people being involved in both of those training approaches.
Because I haven't seen much improvement through using arms, as I participate in the FES rowing program, and okay. I have seen massive improvements in my aerobic capacity using the stationary rowing along with FES, and so, but I haven't seen anything much with arm to get up aerobic capacity. So I'm very intrigued by the medical, the medications that you're adding to this. So is it possible to do a trial to learn more about what those medications are and how they could be paired with other exercise modalities?
Absolutely. I think that this is a really important study because it's our first opportunity to look at the combination of an exercise approach with these medications in people with SCI. But I think if we find this to be effective, there would definitely be the potential to look at comparing other exercise approaches and if some might enhance it more or less. But one thing is that the people are getting the same baseline exercise approach. So so it will get an understanding of the additional benefit of these muscle and bone boosting drugs on top of that. Then in future, we could look at how other exercise approaches might enhance that. Any other questions for any of us?
I've got one. Did you say when it would start?
For the sorry, which one? The
multimodality intervention, when would that program start?
We are enrolling people right now.
Okay.
We've enrolled, I think, around 20 people already. We've had quite a few people complete the trial, complete their engagement in the trial. So we're actively recruiting, as they say.
How many are you looking for?
We're looking for 88 people in total.
Okay. Yeah,
So we
you
still
did-
have.
Got it.
Still have a way to go, and we're really eager to talk. And I know this is a really abbreviated. We'd love to talk more and explain it more to anyone, even if they just have some interest in it.
Thank you.
I have a question. This is Abby. I'm sorry if I missed the
Yeah,
intro on how to raise my hand. I can't seem
that's
to
okay.
find the right emoji or icon or whatever. This is kind of builds on Chris's question. Do the participants in the study have to control for other forms of exercise?
So if people are already actively engaged in a very intensive exercise program, we ask them to, we ask for a washout period for them to stop that. And again, we can talk about the more specific details of that. We're just wanting to allow time so that there's a consistency in the training that people are doing across both groups, because it's not a very large sample size overall. But we can, yeah.
Sorry.
It's okay.
I have a question.
Sure. Hi.
My grandson's injury was just 4 months. Is that too soon? It happened 4 months ago.
Well, right now it would be too soon, but we take people within, he needs to be 6 months out to begin the trial. But if you wanted to reach out to us, we're going to be recruiting for at least another year and a half or so. So he absolutely he'll become eligible in a few months. So we would be really happy to just even have his name and then connect with him early in the new year.
Thank you.
We will provide all the information on the attendees if after the presentation. So we're going to jump over to the next speaker, who is from the Inspire Lab. And Will, do you need me to add anybody, or is it just you?
I'm going to present, but Angela is also going to talk. I can
Okay,
share.
I've got you both. Okay, I've got you
Two
both
of
as
us.
co-hosts. So from the Inspire Lab at Spaulding, here are Will and Angela. Thank you.
Let me just. Not sure if I have the ability to pull it up.
Thanks for hanging with us while we share a PowerPoint.
Sure. Will, do you have the ability to screen share?
Yep, I just, I think I just.
Here we go.
Great.
There you are.
There we go.
So sorry for that.
No worries.
Okay, is this good? Everyone see it properly?
Perfect.
Okay.
Well, good morning, everyone. Thanks for joining us on a Saturday to kind of listen into on research. So we're really pleased to have the ability to speak and get you to hear about what we're doing over in Inspire Lab. So Inspire Lab is over at Spaulding, Cambridge, I'm Angela Link. I'm a physical therapist. I work inpatient over at Spaulding, Charlestown, but I also work as a clinical researcher at Inspire Lab. And then I'm going to be joining with Will today. So Will.
Hi, everyone. My name is Will. I'm the clinical research coordinator at the Inspire Lab.
So today we'll talk about a little bit, just a brief overview of two things that we're looking at specifically at Inspire Lab in regards to helping people move better in regards to acute intermittent hypoxia, as well as transcutaneous electrical spinal stimulation. So next slide, Will.
You got it.
And then we got that, so we're good. Next one.
So as you can see here, our team is big. We have a lot of backgrounds of the people who come into the lab and work with us, from therapists to physicians to postdocs. researchers and engineers as well, all working to try to look at how we can improve rehabilitation with engineering as well. So here's some pictures from the lab. As you can tell, there's some different studies going on right now that are all non-invasive, and we're focusing on upper and lower extremities currently at the moment, which we're really excited.
So we'll delve into acute intermittent hypoxia first, and then the transcutaneous stim next. So you'll see acute intermittent hypoxia, or AIH in short. So that's essentially looking at a decreased concentration of oxygen for short bouts. And then next slide, Will. So just a brief background. So obviously a lot of research goes into our rat models. So a lot of very specific respiratory researchers were noticing when they were working with these rat models that in this respiratory kind of housing area, that there was, when they kind of had various stressors, they were noticing an uptick of various good nervous system chemicals that we know promote neurorecovery. So specifically BDNF and various other ones. So that's one that we get really excited when we see in that area. And then in regards to almost doing this research for a decade, we've moved it from rats to now humans with a spinal cord injury, because we found that one, it's safe. Two, we're noticing that improved neuroplastic chemicals. And we've noticed that an increase of those chemicals with this breathing treatment, that they're actually correlated with functional improvement, specifically locomotor or walking and gait. Obviously, we've adjusted it for the human model. It's about a 45 to 90 second bout, 45 minutes total. So you'll see kind of just like an oxygen mask, like collegiate athletes sometimes use. Vitals are monitored throughout. But it's kind of essentially going from like the bottom to the mountain to the top. Where it's really breathing treatment. Slide, Will. So you can just click through the words, Will. So why are we making patients breathe less? So we know based on what we've found for almost the last decade that there's that increase of nervous system chemicals that are related with neuroplasticity. And we have found that it's safe over the period of time using this with humans before we've actually started doing now the therapy part added to it. So we've deemed that it's safe. And then we're also we've noticed that when you add that stressor, like the right amount, it's actually beneficial. So now we're just looking at using that neuroplastic effect that we're finding and adding now I'm going to train it to be specific the way I want it to. And then also what I kind of like to relate when people are thinking, oh, I don't want to do like necessarily a breathing treatment. If you think about it's the right amount of stressor to make a change. So if you think of a weight, when you're doing weight training, if you're doing a certain weight, if you're too heavy, obviously, yes, that's going to injure you. But if you don't do any weight or you're doing a very small weight, you're not going to initiate a change. So if you find that appropriate middle ground weight, you do cause a stress to your muscle system, but in regards to that actually will increase your size of your muscles, so you get stronger. The same thing with your breathing treatment. Obviously, we don't want to do too high, but if we can find the sweet middle ground, then you're implementing change. And when we implement change, then we want to actually train it and pair it with rehabilitation as well. Next slide. And then so just to kind of give you some basic information about almost this decade of research. So we found that using this, it's safe, it's non-invasive, and it's easy to utilize. And when you utilize it before the rehabilitation, the walking task practice, we see that there's this additive effect. So breathing treatment in itself, we found benefits, but we found obviously when you do a breathing treatment for that 45-minute period, you do walking training right afterwards, it enhances that outcome. And we're noticing it also with things that a clinician, like a physical therapist, can measure. So things like lower extremity strength, walking speed, walking endurance, and we're seeing those pretty soon afterwards, but we're also seeing that people maintain that. And then this isn't even in the chronic population. So like a year and plus afterwards, we're noticing those improvements. And then another one that we have actually actively going on in regards to recruitment, working with the Department of Defense, is anywhere, so folks even earlier after injury, so this 2 months to a year out, and pretty much anyone, whether they're walking or they don't have lower extremity movement right now, we're kind of taking recruiting a variety of individuals with spinal cord injury, because we want to see if we do it sooner on in an injury, do we find improvements? Also, if we do it with folks that maybe are sooner on, but they don't have lower extremity movement even at this moment, do we notice that there is some kind of neuro recovery afterwards as well? So that's an exciting one that we're actively doing and looking to get a good chunk of people with. Next slide, Will. And then this is just a list of publications. So we'll talk to you about our website as well later. So next slide.
Got it. Thanks, Angela, for going over some hypoxia stuff that we're doing at the lab. I'm going to now be talking about transcutaneous electrical spinal stimulation. This is another study that we're doing in the lab. Some brief background of spinal cord stimulation, that previously there's been research with epidural stimulation, which is going within the skin, and it requires surgery, but there has been shown to have improvements with upper extremity function, hand and arm function. Now what we're looking at in the Inspire lab is, can we try to have similar outcomes with hand and arm function, but by just putting sticky electrodes on the injury site, and this is all non-invasively, so it's just like sticky electrodes that go around the injury site, and people that have even been 12 years post-injury have still shown to have hand and arm function. So this is a really exciting project that we're doing right now. So this is kind of just an overview of what the electrodes look like, and on the top left-hand corner, there's just the electrical wave that's going through the skin. And why this is really cool is because we use a really high frequency, which allows deeper penetration, so we can actually try to target the spinal cord itself. And the higher frequency also allows a lot lower pain while we're doing the stimulation. So with the combination of that, it's able to kind of reach in deeper, so can target special tissue. So right now, what we're on the project is we're in a clinical trial working with a company who's trying to seek FDA clearance. So right now, we have a 4-month study that is 2 months of a functional task practice, like upper extremity OT. This is kind of like the wash-in period to see how the OT goes. And then in months 3 and 4, we start using the electrical stimulation with OT in combination to see if there's additional improvements. But we are looking at other stuff like bowel bladder, and there are safety concerns of what we're trying to look into as well with a bunch of questionnaires. So
and then before we go on, just because this is there was one slide that we didn't get to edit, so my apologies, but in regards to the safety concerns, there's things that, since this is something that obviously clinicians are not doing in the hospital and the clinic environment right now, there are things that they are monitoring in regards to, does this affect bowel and bladder? Does this affect things in regards to just like blood pressure aspects? So they're not things that we've noted issues right now, but they're just some things, since they are looking at clearance, we're obviously seeing, one is their concerns, but two is that something actually that we're noticing any neuro recovery as well in those areas, besides just arm function, but bowel and bladder, sexual function, things of those nature.
Yeah. That corner is basically saying we're still looking into it, and please don't take like your electrical stimulator that you have at home and just put it on your neck. But we are looking at like bowel and bladder improvements as well.
So in regards to where do you find more information, so we'll kind of show you our Inspire Lab website as well, but we're looking for folks pretty much whether they're looking to work on upper extremity function, lower extremity function. We pretty much have studies that are anyone from 2 months out to years down the line, pretty much Asia A through D, the various levels. So we pretty much have something for anybody if they're interested. So don't hesitate to call us. If someone is potentially appropriate, don't hesitate to have them outreach to us, because I think this is great, just getting connected with everyone. And then next slide. And then this is our website. So we actually recently updated it. So we would love you to take a look at it and see if there's anything of interest to you. So it's inspire/lab.org, where you can look at all of our specific studies, see if like the inclusion and exclusion, like if someone's appropriate for a various study based on their injury level, their age, things of that nature, but also just to kind of see the lab and see what we're doing. So have a look. We're excited to show that new website off.
Thank you so much, Angela and Will, from the Inspire Lab at Spaulding. We have a couple minutes for questions.
Sure, thank you.
I have a question. Is there a difference? Is there a difference between, my grandson has a penetrated injury, not a blunt force.
Mhm.
Does that make a difference with this therapy that you guys are talking about?
So you're just saying a blunt force, like a spinal cord injury caused by a blunt force, correct?
Right. He has a penetrated one because he was shot in the neck versus a car accident or surfing accident. And I just wonder if the difference between the blunt force and penetration would make a difference.
It would not. So essentially we're working with traumatic spinal cord injury. So either of those mechanisms are under our house. So.
Okay, thank you.
Yep.
This is Abby again, just to double check the tests. Trials underway now are for just the C-level injuries, not the T-level injuries, but is there hope of applicability to the T regions?
So Abby, thank you. That's a good question. So yes, right now they're at the cervical level in regards to Inspire Lab studies. That is something that I think is very interesting down the pipeline, because even with the cervical spine, we're curious if there's any benefits that we're noticing kind of downstream too. So that's why not even just bowel, bladder, sexual function, but trunk control, mobility, things like that. So I can't speak to directly that yet, but that is of an interest too. So keep posted with us.
Great, thank you so much. Just in the interest of time, we're going to jump over to the Paralysis Center at Mass General Hospital.
Hi. How are you? This is Ben Johnston. I'll be giving the talk the rest of the day.
Let me make sure I have you added as a co-host. Yeah, you should be good to go. Thank you.
Very good.
Perfect.
Very good. So my name is Ben Johnston. I'm a PGY4 resident at Brigham, and I'm currently the Reconstructive Neurosurgery Fellow at the Paralysis Center under Dr. Justin Brown. So the Paralysis Center is a very encompassing group of clinicians. There's plastic surgeons, orthopedic surgeons, neurosurgeons. We have PT, OT, and then we have a number of research staff working on a number of projects to overcome paralysis. And one of the things that is very important to define is the kind of extent and characteristics of a spinal cord injury. So on the left here, you have the cross-section or sagittal section of a spinal cord injury. And in this center zone right here, you have the actual point of contusion of the cord. Above it, you have still remaining intact cord where neurons can extend outward and still exert control on muscles. And then below, you have part of the cord that still has the cell bodies that are going to be able to control muscles, but you don't have the connection to the brain. And the reason this is so important is because the main function that we're trying to exert over our muscles extends from those cells in the anterior horn, those lower motor neurons, and extend out to control our muscles. And so this is what we really are trying to define in terms of the ability for recovery in patients that have spinal cord injuries. If the injury, again, is above the actual focus point of the injury, then the nerve should be able to extend down from the brain, hit a motor neuron synapse, and you should be able to control your muscles. However, if the injury is if the lower motor neuron is in the zone of injury, you basically will never be able to have those muscles controlled by those neurons again. So we do have a project underway to actually recreate those motor neurons through induced pluripotent stem cells, which we will not really get to today. And then the third category is when essentially the muscles are not working below the injury. And that's again, because you don't have a connection to the brain, but instead the motor neurons are still alive. So this is very important to define in our patients because a patient defined with a C5-6 injury, which in this case is both panels, As you can see on the left, this is a very small amount of damage to the cord with this focal point right here. Whereas in the right panel, you can see this very long signal change. So this is a much more extensive zone of lower motor neuron damage. And the reason lower motor neuron damage is so important to define is essentially the clock is ticking on all those muscles. The muscles are going to fibrose after they atrophy, and those pathways within the muscle for the nerve to regrow down for any type of nerve transfer or other intervention start to close off. Whereas in an upper motor neuron injury, the injuries below the lesion where the motor neurons are still alive, just not connected to the brain, you can consider nerve transfers at a much longer window because those muscles essentially are still innervated, they're just not functionally controlled. So what is a nerve transfer? In its essence, you're taking a nerve from above the injury and you're transferring it to a muscle that was previously innervated by a nerve below the injury. And the reason this works is because this muscle up here is fulfilling a function that is also done by another muscle. So for instance, flexing the elbow has several muscles that control that function. And so you transfer one of the nerves that does that to provide a new function for the patient. And this is the only way it would become a net benefit. So here's the kind of nerve transfers in a nutshell. So we have a patient here. You can see scrunching the hand. You can see flexing the elbow. And we're going to show a nerve injury here happening where the musculocutaneous nerve is injured. And we'll soon see that the elbow doesn't flex and the muscle begins to atrophy. So what we can do is we can find the branch going to the biceps, and we can take off a small portion of the nerve that controls the hand flexion, the median nerve. We can coapt that, and then the nerve regrows into that branch to the biceps, and you start to regrow some of the function of that muscle. Now, here's the real trick to nerve transfer. This is the whole kit and caboodle. When the patient thinks about moving his fingers, he's activating the biceps because you've transferred that branch of the nerve. So the patient needs to learn to flex his fingers to be able to have a functional bicep activation. And so this takes a lot of time. So what do these transfers look like? Well, I'm going to go over 3, and then we're going to talk about something for innervating a lower extremity target. So this is a functional transfer for extending the elbow. So this is somewhat of a big diagram, but I'll focus you here on these little windows. In A, you can see the infraspinatus muscle and you can see the teres minor. So both of these muscles are going to provide some external rotation, getting the arm out to the side for the shoulder. And there's a little branch that we can take because there's still the infraspinatus performing the function. And we'll transfer that little branch of teres minor to the triceps, which you can see up here. So clinically, this looks like a patient that doesn't have any elbow extension. You can see this patient unable to get beyond horizontal. This is Dr. Brown in the background here, helping him with his shoulder stability. And then I want to emphasize this is a year after surgery, a very long time frame for recovery of that muscle group and learning enough control to get. So now this is providing function, reaching above you, getting something off a shelf, and this is just from one nerve transfer. Another nerve transfer that's part of our repertoire is for opening the hand. So there are several muscles that provide supination or flipping the palm open, and we take 2 branches of those, or depending on the patient's anatomy, and we transfer those to the posterior compartment of the arm, the part that extends the fingers and extends the wrist. And that allows someone to open up their hand. So this is a little bit more footage of kind of how this all works. So intraoperatively, we have to identify all these branches. So here's Dr. Brown here stimulating just the branch that's supinating. You can see the wrist turning over. And that's not a very significant function. You'll have other functions to be able to perform that. And then you can see that we found the branch that is extending the fingers and the wrist as much as possible. It's a strong contraction. And so now when the patient activates supination, meaning trying to open up the palm, you can see the fingers come with it. And over time, hopefully those two functions will become independent. So opening up the hand and then flipping open the wrist are kind of two separate activities. The last I'll just talk about is closing, so grasping something. So we talked earlier about transferring a nerve to the biceps. We're doing the opposite in this case. We're transferring an elbow flexor into the hands. So the brachialis branch is a muscle that controls elbow flexion. And in this case, we take that little branch and we coapt it into the nerves of the forearm that control finger flexion. So in this case, the patient you're going to see is thinking and doing a bicep or brachialis contraction, and you can see that the fingers are closing. So now on for something completely different. So there is a lot of research underway that Dr. Brown has funding from the DoD to pursue to kind of better characterize the electrophysiology of these repairs. This is something quite a bit different, which we have funding for as well, which is trying to innervate the bladder. So if someone has a very low spinal cord injury, they essentially will never be able to have the lower motor neurons to contract the bladder again. So two very smart researchers at Temple, Mike Ruggieri and Mary Barr, have worked with Dr. Brown for a long time, and they pioneered this model in dogs for essentially 2 decades. So they transferred nerves that are motor nerves into the bladder, and when they had the dogs activate those nerves, the bladder contracted strongly. When they relaxed the nerves, the bladder stopped contracting. So this was the kind of one of the meetings that we had to discuss how to properly set up the anatomical transfers for a patient that we didn't even know would come our way. Eventually that patient did come. So we had a 30-year-old gentleman who had a sacral tumor that required very extensive resection. And all of the nerve roots coming off of the sacrum had to be sacrificed to save him from that tumor. So he would never recover function of his bladder. Those nerve roots are gone. But the nerve roots controlling his lower extremity, flexing his knee, bringing his knees together, those are still there. So what we propose is that we would take a small part of the obturator nerve, so that's over here. The obturator brings your knees together. And inside the pelvis, we would transfer that nerve, just like was done previously in Mike and Mary's research, to the anterior vesical branch of the pelvic nerve, so that the patient would then think and bring his knees together, and that would provide enough of a signal to contract the bladder. So this is the actual kind of setup for how this is all done, a little bit more OR footage. So we have to be able to see how the medial compartment of the leg is activating the obturator component. Our colleagues in urology were able to get us access to the back of the bladder. And then this is Dr. Brown identifying the branches of the obturator and splitting out just a branch. We confirmed that it was nervous tissue that we were being transferred. And then we eventually coapted the nerves once we felt confident about the transfer. And this is a really good sign of how the Paralysis Center works in terms of collaborators from very different fields. Mary is a PhD in anatomy. Mike is a PhD in pharmacology. They had been working on this project for 25 years or so. And this transfer and watching this come to play was their highlight of their academic career. So we are very interested in the Paralysis Center in finding other collaborators with such type of projects and finding patients that we can better help. So I'd like to thank all the other members of the Paralysis Center and just acknowledge some of the very kind funding that we received for this work.
Ben, thank you so much. And we have a few minutes left for questions.
I have a question.
Sure.
A nerve specialist from Mass General saw my grandson at Spaulding and talked about doing the nerve surgeries in his arms. Is that similar to what you're talking about, sir?
Was that nerve surgeon Dr. Brown?
You know what? I wrote down what the heck was his name? Is he out of MGH?
He is, yeah. So the Paralysis Center is Dr.
Brown.
Yeah, I would guess. So Dr. Brown heads the Paralysis Center. He's my mentor, and he has appointments at Mass General Spaulding and essentially all of the MGB facilities that are working on paralysis reversal by nerve transfer, he would be the go-to person.
Okay. And is there anybody doing stem cell research?
Yes, we are doing stem cell research. We are looking at how we can make stem cells in the lab, which we have made. And then we are working on ways of not injecting those into the spinal cord, but rather injecting those at the muscle of interest, and then having those be spots where you could stimulate and control the muscle remotely, or just providing a way for the muscle to prevent atrophy so that later on they become a better target for nerve transfer. So that's currently under investigation right now.
All right. Thank you so much, Ben. And we will now pass it over to Dr. Linman, who is with the Neuroimaging Laboratory at Spaulding.
Hi, everyone. Thank you. There's some fantastic work going on, obviously, and I'm really proud to be, in this seminar and then share what we're doing that relates to a lot of these studies. Just to get this started here.
Perfect. Thank
you
you.
all for that. Great. So my name is Klaus. I have been at Spaulding for it's almost 3 years now. And before that, I was at Boston Children's Hospital, primarily working on brain imaging of pain conditions. And but now my focus is totally on spinal cord injury and pain, also in pain conditions after spinal cord injury. So I use PET MR. Let's see if this starts. There we go. And the difference between an MRI scanner and a PET MR scanner is that aside from measuring spinal cord and brain function and structure, we can also look at specific molecules. So in this case, we are looking at a cell called microglia, and they are essentially the white blood cells of the brain. And after an injury, the microglia activate and they start expressing different surface proteins, one of them being the TSPO protein. And the way PET works is that we label a drug that will bind to TSPO. And that drug is injected, and then we can detect where that drug accumulates in the brain and the spinal cord. So this way, we are getting a measure of active ongoing inflammation in the neural tissue, and this gives us much more specific information about what's happening on a molecular level. So our very first results are on microglial expression or brain inflammation after spinal cord injury. And we see that this region of the brain called the hippocampus, that's where it's typically a memory region, but it's also involved in pain processing. And that's also one of the main sites for new neurons to be born in the brain. And we see that in folks with spinal cord injury, there's an elevated level of microglial activation here, or an elevated level of brain inflammation after SCI. So why does that matter? Well, we think that this could be a good target to treat, both in terms of neuropathic pain, but also just general brain health. We do not want brain inflammation to be ongoing in these chronic patients. So one of the ways we are now looking into targeting this is through exercise. So exercise has been shown to be good for brain health in general in the able-bodied population. And in animal models, we know that exercise can actually increase hippocampal neurogenesis. So the hippocampus can grow in patients or in rats that run on a treadmill a lot, or one of those wheels. So together with Andy Taylor's lab, we are looking into the effects of FES rowing. So this is a full body exercise. I think Andy's lab will talk more about how this actually works.
Dr. Linman, sorry to interrupt, but can you go to full presentation mode?
Yes.
Oh, this is the doctor. That's.
See, let me see. Mine. Let me try that again. Is that better?
That's perfect. Thank you. Perfect.
Okay, thank you. So the study that we have up and running right now is looking at the effects of 12 weeks of intensive aerobic exercise through FES rowing. And so people will come in, they get a PET-MR scan, or they actually get 2 PET-MR scans. And then they're randomized to either rowing or a waitlist control. After 12 weeks, there's a second set of scans, and then you go into the other group. So then you go into the 12-week waitlist. And our inclusion criteria are ages 18 to 6 years old, and people about less than 6 years from injury, up to, we have 3 months to 6 years since injury. So we don't do super acute patients, but as soon as you're medically stable, you can go in and begin rowing. And the injury levels are C5 or below, and it's essentially defined by if you're able to have some muscle function in your upper arm so that you can do some rowing. And our results, well, they're very preliminary, but we know that FES rowing does improve your aerobic capacity quite a lot. This is data from Andy Taylor's lab, where just after 3 months of rowing, you can get an increase of about 7% in your VO2 max, which is a very big increase in terms of exercise and work capacity. And in our first case study, we noticed that after 12 weeks of rowing, we saw an almost complete reduction of neuropathic pain in this guy. He had some growth of regions of the hippocampus, and we also see that this microglial inflammation in the hippocampus seems to be decreasing by a couple of %. So obviously this is very exciting news that this treatment may perhaps change and improve brain function and brain health. So in summary, we are now about to publish, there's evidence of brain inflammation after spinal cord injury. And we think that one good treatment for this, non-invasive treatment, is just intensive aerobic exercise to reduce both pain and brain inflammation. So the second part of my project, and this is, very much will benefit a lot from what Ben just mentioned about how the spinal cord injuries differ between patients. And the question we're asking is, how complete are these complete spinal cord injuries? So on the acute MRI, you can have quite different situations where there's almost surely a complete tear of the spinal cord, or if you have something like this, which more of just a slight change in tissue contrast of the spinal cord, but you can still have a complete loss of function below the level of lesion. So after an injury, typically what happens is you have the acute trauma, and then there's apoptosis and necrosis. So basically a part of the cord dies, and around the cord there is a shell of a glial scar with some remaining tissue. And you'll notice these neurons here have lost the myelin, and that's what we're targeting, or that's what we'll be looking at more. And below the level of the lesion, there's typically ischemia, or a loss of perfusion. So there's not enough oxygen coming to the cord below the level of lesion. So how do we know if the spinal cord is still intact in some way? Well, one way of looking at motor function coming from the brain and impacting the body below a lesion is doing something simple like the Gendrasik maneuver. So basically, if you clasp your fingers together like this, and you bite down and pull apart, then your patellar, your knee-jerk reflex, will be enhanced. So this works by essentially a greater outflow of motor activity from your brain, and that will impact the responsivity of your legs. And this actually seems to work in some spinal cord injuries with complete injury. So this would suggest that some nerve signaling is getting past that lesion and impacting your body below the level of the lesion. And going the other way, there are now 2 studies indicating that in ASIA-A complete patients, if you do a stimulation of the toe, the patient doesn't feel anything, but a slight stimulation of the feet will lead to brain activity in the right spot. And this would be the primary sensory cortex where the legs are represented. So this happens in about half of the subjects that have been investigated. There are 2 studies now, so it's been replicated. So this suggests that some neural signal can get past the lesion. And what we think might be going on is that after an injury, the remaining nerves that pass the lesion, they're still there, but the myelin disappears. So the myelin is a sheet of fat that covers the neurons and improves the neuron's ability to fire quickly and fire repeatedly. If the myelin disappears or is removed, the neurons may still fire a little bit, but not as often and not as consistently. And when myelin is removed from the neurons, these potassium channels are exposed. So the way we look at this is we have a drug that targets these potassium channels. It's called Ampyra, and it's been used in multiple sclerosis to improve walking speed. It works in some spinal cord injury patients. There have been a couple of clinical trials, and it's not necessarily better than placebo, but that's probably because maybe only half of the population will have spared neurons that can benefit from Ampyra. So the project that we're just now starting is we're radiolabeling this Ampyra and looking with PET and MRI to see if there is an increased level of demyelination in the injured spinal cord. This is the first picture we ever got. This is a healthy female using this new PET tracer. And there's not much uptake in the brain or in the spinal cord, which is what we hope to see, that the brain and the cord are fully myelinated. And most of the tracer just accumulates down here in the bladder of the subject. So in a couple of weeks, we will study our first SCI subject using this tracer. And obviously what we're hoping to see is that there's some increased level of demyelination at or around the lesion. So that could potentially be a new treatment target to look at. In addition to the PET study, we're also looking at this functional activation and sensory activation. So we'll stimulate people's feet and see if we actually do get any sensory activation in their brain. So indicating that there is some form of connectivity between the 2. So in summary, this study suggests that the residual axons in the injured cord has potential for maybe some functional improvement. That obviously would mean a lot. Just the slight improvement would be very meaningful for patients. And by directly measuring these potassium channel expression, we hope that this will be a more sensitive biomarker for demyelination than current MRI studies or current clinical evaluations. And just the larger picture is that these methods give us evidence of potential targets, and it also allows us to examine how our interventions like exercise or intermittent hypoxia or drug studies, or even working with Dr. Brown, how nerve transfers can change brain inflammation and change brain function, and perhaps induce remyelination of the cord. And with that, yeah, thank you for your attention. So you can contact us at spinalcordinjury@partners.org. And SD Goldberg is my research assistant who will be talking to you and explaining more of the studies if you're interested in participating. And Ryan and Andy are my collaborators at Spaulding. And Pedro Brugolas is the inventor of this new tracer that's at the Mass General. So thank you.
Thank you, Dr. Linman. We have a few minutes for questions.
This is Addie. I have a question. Could you go over again how it is that the brain becomes inflamed with an injury that's C or T or even farther down?
Yeah, that's a great question. We think what's going on is that part of the somatosensory cortex, those regions controlling your lower body, are not activated. So the brain starts to reorganize. And as part of this reorganization, there's a shift there's an activation of these microglia. And another aspect of it is with neuropathic pain, we know that that will also induce a slight neural inflammation, even in things like lower back pain that induces brain inflammation. So what we're hoping to see is, or what we're expecting is that patients or subjects with neuropathic pain will probably have more neural inflammation than those without neuropathic pain.
Thank you.
I have a quick question. Let's see, can I?
Sure, go ahead, Al.
Yeah, I have a lot of neuropathy going down both legs, and I think it's, due to inflammation as well. And my injury was in 2018, and I'm still having the same issues after fusion with the neuropathy and all of that. So I'm wondering if there was any damage to the myelin of the nerves and things like that too, because I've only seen a neurologist once, and he didn't give me much information. So my question is, in an incomplete injury, I have a lower back lumbar problem, but I have a lot of that neuropathy and inflammation. I'm just wondering, are you looking for, are you studying also the incomplete injuries as well? I know you touched on complete injuries.
Yes, we're studying both complete and incomplete injuries. We're not at a state where we could say if either inflammation or demyelination is driving neuropathy or neuropathic pain. We don't know that yet, but certainly that's one of our main questions. Are the intact neurons, are they driving the pain, or is it the lesioned neurons that are sort of out in the open signaling nothing, and that's interpreted as pain? That's the other potential answer to that.
Oh, that's good. Thank you.
Thank you so much, Dr. Linman. In the interest of time, we're going to move to Dr. Taylor in the cardiovascular research lab at Spaulding.
Oops, sorry, my wife just walked in the door and yelled, "I have lunch." Let's see. Let me share screen, I guess. Let's see. Hang on just a second. Share. Does that look okay? Can we see that?
If you can put it on presentation view, Andy, I think you're.
Oh, I am. You know what? I've got it on a smaller screen. So let me stop share and switch this around. I think it's always going to look the same. I don't think I can change it. Is it too small?
It was good.
Is it too small, or is that okay?
It's still small, but that's okay.
Are you seeing? You're seeing this screen then? That's so strange because I have it on presentation. Let's see. One more time. Oh, I have to reopen it. It's because I've got two screens running here. It just closed down on me.
And if you want, I can go jump over to Dr. Selinsky and have you come in.
No, it's just, I've got two screens running, and so it's going to be small. Is it this presentation or is it this one over here?
Yeah, no, we can see it. It's fine.
Is it this one where my mouse is right now?
I can't see your mouse, but I see.
Can you see my mouse now?
Yep, we got it. Yep.
Okay, all right, that's what I want it to be. Okay, it's going to be a little bit small, but that's just the way it is. Some of you may know that I've been pursuing appropriate exercise interventions in spinal cord injury for some years now. And in fact, we have taken some of this work and moved it into a program, the Spaulding Exercise for Persons with Disabilities program. And so what I'm going to present today is building on the past 10 years of work in this area. And I shouldn't be running two screens at once. So the background here is that there are cardiometabolic implications for the limitations to exercise in those with spinal cord injuries. We know that exercise training intensity inversely relates to risk for cardiovascular disease as well as other diseases. So in essence, more vigorous exercise is greater overall health benefits. And interestingly enough, the American Heart Association says that they found that more than half the reduction in risk occurs when people move from the least fit group of individuals just to the next least fit group of individuals. Now, what does this mean for spinal cord injury, especially for those with high level spinal cord injury? The maximal or the minimal exercise intensity that's necessary to reduce risk can be greater than maximal exercise capacity in those with high level spinal cord injury. However, regular exercise can have beneficial effects, and what's critical to that is engaging more muscle mass. Now, what some have done to engage larger muscle mass has been FES exercise. So this is FES alone, which is leg or leg plus arm cycling. The problem with FES alone is that you do see local improved muscle strength and bone density, but there is really not that great of a training effect. In fact, it's less than in able-bodied at the similar workload. And so what we're really looking at is only locally stimulated muscle activity. We're not looking at whole body exercise. So the way we've approached this is hybrid FES exercise. So legs combined with simultaneous arm exercise. So either cycling or rowing. We use the rowing because it's a more natural form of exercise. Rowers are relatively cheap and accessible, and we simply add FES of the legs for individuals to generate a rowing stroke. So this had the advantage of higher intensity than either upper or lower body alone. The legs are loaded, so now there's a stimulus for the bones and muscles to adapt. It's a whole body exercise response, much as when an able-bodied person goes for a run. However, the thing that we've found is that in those with high-level SCI, the training in response to this form of exercise is limited by their respiratory capacity. So let me show you some of our data. Here is some data that we've published in those with low-level spinal cord injury, okay? And this is their peak aerobic capacity in relationship to injury level prior to training with the FES exercise. And if you can see here that the level of aerobic capacity is determined by injury level. So those with higher injury levels have lower ventilation and lower peak aerobic capacity, okay? So this is before 6 months of training with the hybrid FES. Now, after training with the hybrid FES exercise, we actually lose that relationship to level of injury. So what's happened is we've circumvented the lesion. So we've given more muscle mass to everybody, regardless of what level of spinal cord injury they have. Now, this is different in those with high level injury. So here we have individuals with injury T2 and above who can use the FES rower. And this shows before and after the training. So before the training, we see that there's a close association between aerobic capacity and the ability to ventilate. But then after the training, it actually becomes more important. So what happens is that in essence, in these individuals with high level spinal cord injury, it is ventilation that's limiting their ability to exercise. So they train up to that ventilatory capacity and they can train no further. So our work is to try to overcome this with a couple of different approaches. This is just a schematic to sort of suggest this is what's happening in high-level SCI, that before training, the lungs capacity far exceeds what the body can do. So even though we're adding more muscle mass, the lungs can meet that need. But then after training, the muscles are trained, and now the lungs lag the legs. So there are two approaches that we're taking to try to overcome these limitations. One is non-invasive ventilation. It's kind of like a CPAP machine. And this has been used in other populations that have ventilatory restrictions in response to exercise. So we know in those with obstructive disease, using NIV during a single bout of exercise increases endurance and reduces breathlessness. In restrictive respiratory diseases, so people who can't breathe in a lot, kind of like high-level SCI, training with NIV improves endurance by more than 70%. And in obese individuals with inspiratory restriction, NIV during exercise training results in 4 times greater improvements in maximal exercise capacity. So if you can just assist them in breathing, they can achieve higher levels of aerobic capacity. And in fact, we've done some preliminary work with this and found that, in fact, those who have already trained with the FES rowing with high-level injuries, if we give them in a single bout of exercise, non-invasive ventilation, they improve their exercise capacity. So that suggests that the muscles are trained beyond the pulmonary capacity. So this is one way to overcome that. Another way that we're exploring to overcome that is with the drug buspirone. This is a drug for anxiety. We know that after a spinal cord injury, because of the lesion, the respiratory-related activity in the brainstem and spinal cord is reduced because the afferent inputs, the nervous inputs from the lungs are lessened. And we know in rats that this drug can reverse impaired ventilatory response after a high-level SCI. There's no prior work in spinal cord injury, but there is some other work in other populations that have impaired control of respiration. So for example, an individual with a brainstem surgery and an individual after stroke, just a single dose of this drug actually improved their ventilatory capacity. And longer term treatment in MS and Rett syndrome has shown that we can reverse loss of breathing control in these populations. So building on our prior 5 years of funding, we've moved forward with an NIH, another 5-year funded study from NIH to look at the potential of these two, what I'm calling ergogenic aids, to improve exercise capacity and training in those with high-level SCI. So we're currently recruiting individuals who are within 2 years of injury, who have a higher level spinal cord injury at and above T4, Asia A, B, and C, and are aged 20 to 40 years of age. The intervention is 6 months of hybrid FES row training, so everybody gets trained. And it's a double-blind 2x2 trial of the non-invasive ventilation and the drug. And so this shows basically what that schematic looks like. So some will get both. They may be synergistic effects of the two treatments. Some will get nothing, so they still get the FES rowing. And then some will get only drug and some will only get non-invasive ventilation. Interestingly enough, the sham and the NIV, we actually can fool people into thinking they're getting assistance with their breathing. So half the time people don't know what they're getting, if they're getting NIV or sham. So we can actually blind people to that. Our outcomes are obviously exercise capacity. Because we're interested in cardiometabolic health, we're looking at body composition. We want to see if we can improve pulmonary function as well. We're looking at glucose regulation. And because the drug Buspar does have an effect on sleep, we are looking at sleep quality as well. So I know we're running out of time, so I just want to close, and I should thank all the individuals who've helped with this work over the past, 12 years now. And we've been lucky enough to receive funding from a number of sources to help us move this work forward. We have some other work going on, but we're at the end of this, so I think I will stop here and take questions.
Thanks, Dr. Taylor. We have a couple minutes for questions.
This is Abby again. Sorry to have so many questions. Hello. You know how Sam has benefited from your program. It's been wonderful. I wondered if anybody else in the room would benefit from just a quick explanation of why aerobic capacity is so important.
Yeah, so maximal exercise capacity requires optimal functioning of almost every single system. So neurologic systems, pulmonary, cardiovascular, endocrine, thermoregulatory, and it's basically a surrogate for whole body function and health. In fact, the American Heart Association has recently suggested that that should actually be a clinical measure so we know how, quote, healthy people are. So that number, that aerobic capacity, that VO2 max is really indicative of overall health. And what's interesting is that that relates to so many different aspects of health. So even it relates to falls in older individuals, for example. It relates to depression and anxiety. So, you know, I didn't give my exercises the poly pill talk, but, you know, if you ask me, I can tell you about that.
All right.
I have a quick question. As a participant, I know that the studies are looking at maximizing the improvement, but just doing the exercise itself without NIV or boost bar still has a huge benefit for people. And is there a way for people to get into rowing without being part of these studies?
Yeah. I mean, you know, we're with the pandemic, we had to go to sort of reduced capacity, but we're coming back. You know, it's really sort of sad because we were on the cusp of actually growing when the pandemic hit. This is the Exercise for Persons with Disabilities program at Spaulding. And so then it hit and we had to actually ramp down. So I think things are coming back. So yes, if you have anybody who's interested in pursuing exercise, send them our way. We certainly, you know, our goal is to exercise everybody.
Great. Thank you, Dr. Taylor. Thanks for the questions. And we'll now go to Dr. Solinsky's studies, and I believe Katie is going to be presenting those.
Yeah, let me just pull up the slides. One moment here. Okay, can everyone see those?
Yes, perfect.
Perfect. All right. So hi, everyone. My name's Katie Burns, and I'm the research assistant supporting the work of Dr. Ryan Solinsky, like Dave said, in the cardiovascular lab at Spaulding. And I'm going to talk to you guys about the main goal of our research, which is understanding secondary complications experienced after spinal cord injury. And these secondary complications are really important because they pertain to issues like bowel and bladder dysfunction, blood pressure dysregulation, in which your blood pressure might spike way too high or drop way too low, even to the point where you might feel like you're going to pass out, and skin-related problems like pressure sores. And given how often people experience many of these complications and really how disruptive they can be to day-to-day life, our research really focuses on understanding why certain people experience these issues after injuries so that we can work towards reducing these secondary complications in the future. And in thinking about the secondary complications, we're specifically really interested in the regulatory mechanisms that are going to control what is known as, or are going to be controlled by, rather, the autonomic nervous system. And the autonomic nervous system operates in the background or kind of like behind the scenes to control things like blood pressure, breathing, heart rate, bowel and bladder function, and blood flow to the skin. And the autonomic nervous system is made up of two parts, kind of like the two sides of the scale. So you'll see that image on the slide here. And you've probably heard about these before. So let's say you're facing a really high stress situation. Let's say you've encountered a bear or a spider, I don't know, whatever does it for you. And your fight or flight response will engage in that situation, act like kind of the gas pedal in a car to give you and your body all the energy it needs to get out of that situation safely. But then once you've exited that situation, your body kind of needs to hit the brakes, so to speak, if we're going with that analogy, and calm back down and return to normal. And you do that through a process called rest and digest. Now, usually people go about life with their bodies kind of working behind the scenes to strike a balance between that gas pedal through the fight or flight mechanism and hitting the brakes with rest and digest. However, after injury, the body's usual mechanisms for controlling that balance are disrupted. So sometimes people tip the scale to one extreme, either tending to be an over or underusing that fight or flight and rest and digest functions, or people might actually like kind of oscillate between those two extremes. And the reason that all of this really matters is because the tipping of the scale is actually what contributes to the development of those secondary complications that I talked about earlier. Since, like I said, the fight or flight and rest and digest functions are really what controls your blood pressure, bladder and bowels, and blood flow to the skin. So taking all of that info that I just threw at you into consideration, we're really conducting 3 studies right now that are specifically investigating that fight or flight response. And one of those studies involves having participants visit our lab in Cambridge, where we conduct an extensive 3 to 4 hour assessment to try to activate that fight or flight activity and see how the body responds. And then at a second optional visit rather, for that study, we ask eligible participants to go to Spaulding's Imaging Center in Charlestown for an MRI, which would create this high resolution image of the spinal cord. Now, a second study that we're conducting right now adds an additional layer to those lab assessments that I just described. And participants actually proceed with subsequent visits that include external electrical stimulation on the skin over the spinal cord in hopes that that might actually be a good treatment option in the future for controlling that fight or flight response. So now finally, we have designed a much shorter and simpler version of the lab assessment. And this third study condenses that 3 to 4 hour research visit that I talked about into a test that would only require 3 to 4 minutes and utilize simple items like 2 blood pressure cuffs and a tennis ball, of all things. And our goal with this study is to actually take what we're learning in the lab and make it accessible. So you don't need to go into a lab for a super detailed assessment, and doctors can actually administer a test that would give you kind of a snapshot, not like the complete picture, but a snapshot of what's happening with your fight or flight response without needing all of the highly specialized equipment that we actually have in the lab. So with all of this in mind, these studies that I described really will provide us with more information in hopes of getting at our goal of understanding the fight or flight response after injury. And ultimately, what we're really working towards here is helping us understand and address those secondary complications so that we can really help you. Thanks so much for listening. If you're at all interested in hearing more about our research or interested in participating, I would love for you guys to reach out. I've dropped our contact information at the bottom of this slide. I know we're kind of tight on time, but thanks again. I know people are probably burned out at the end of this presentation. So thank you.
That was great, Katie. We'll open it up for a few minutes of questions.
Is there?
Go ahead, Chris.
I'm sorry, we're up. Is there? So just contact Ryan's office.
Yeah. For phone number.
For more information.
Yeah. So So you can either email either or both of us. I can drop our emails in the chat too. I can put my phone number too, whatever is easiest for contact information, but certainly we would love to get into the nitty gritty. Either of us are more than happy to talk about it. Someone else have a question? I think I maybe heard.
I'm just really curious. What does the fight and flight have to do with improving bladder and bowel and blood pressure? I'm sorry, so much of this terminology I just don't understand.
Yeah, no, I totally get it. And I did my best to break it down in simple terms, but it's still so kind of like sometimes less than approachable, I guess. So your fight or flight response and your rest and digest are also known as sympathetic and parasympathetic activity of your nervous system. And those are kind of like parts of the autonomic nervous system. And they are actually really responsible for controlling your bladder and bowel function, blood pressure. So they're what are going to mediate kind of how narrow your vessels are, your blood vessels, or like how wide they are. And all of that is going to help to mediate things like blood flow to your skin, the function of your bladder and bowels, and blood pressure in general. So that's why these are all like directly related. It's the part of your nervous system that's happening like without you even being aware of it in the background to mediate those things.
Thank you.
Yeah, of course. I'm dropping the contact information in the chat.
I have a quick question.
Yeah.
Is there any other complications that you found besides those 3 after spinal cord injuries? Is there any like more uncommon complications, or are those just the main 3 things that you're studying?
Those are kind of the big 3 that are within the umbrella that we speak to for Dr. Smolinski's studies. Honestly, he could probably speak to even more if there were like specific concerns that you're experiencing. If you wanted to touch base with us, he would a million times over love to talk more about the specifics too. I think that was Alex. So please reach out. I dropped info in the chat.
Thank you. I appreciate it.
Yep.
Were there any final questions that anybody had for either Katie or? Wonderful. Okay. So again, yes, thank you all so much. This was incredibly informative. I just wanted to reiterate that this is being recorded, and we will upload the entire recording to our YouTube channel. So if you subscribe and click the notification bell, you'll be notified when it's published. Just seeing. Yeah. So again, thank you all. We will get contact information out to you as well if you weren't able to jot something down or if you had questions after the fact. And if, again, any questions, concerns with anything, you can always reach out to anyone from the chapter. You can reach out to me, Heidi at sciboston.org, and we'll be happy to answer your questions and point you in the right direction. So again,
I would just want to thank all of the researchers for doing research that's really about what we live with SCI, not what people who are able-bodied think we would care about. So this is really wonderful. Katie, is your phone number 612 or is it 617?
I know that's weird. I'm originally from Minneapolis, so
okay.
It is truly a 612. Thanks for clarifying.
Thank you. Thanks, everyone.
I also wanted to just quickly thank David Estrada, my husband, David Estrada, and Jenny Min for helping to coordinate this and pull everything together for us. So thank you.
Thanks all. Have a great weekend.
Thanks all.
Thanks
Great
so
job.
much. Take care.
Thank you.
Thank you.